We would like to welcome each one of you to the start of these distinguished lectures in health disparities. We're starting with Dr. Williams. The Center for Health Disparities was established in 2005, and it is a National Institute of Health designated Center of Excellence on Health Disparities and Minority Health since 2005. And we are honored to have today Dr. Williams as our first speakers. Dr. Williams is a member of the Academy of Art and Sciences and the Institute of Medicine for his contributions to the field of sociology, the impact of socioeconomic factors on health. Dr. Williams is an internationally recognized authority on social influences on health and in the field of health disparities. He is a Florence, Norman, and Laura Smart, Norman Professor of Public Health at Harvard University and Public School and Harvard University. He is Professor of African American and African American Studies at the Sociology at Harvard University. He has served as faculty member at Yale. He has at the University of Michigan. And I would like you to welcome Dr. Williams for his presentation. Thank you very much.
Thank you so very much, Dr. Marina de Leon. It's always good to be back at Loma Linda. I graduated, although I didn't attend my graduation, in 1981 from Loma Linda University. And it's always good to come back, as I do regularly for board meetings and other various activities. I'm glad that all of you have taken time out from your busy lives with many responsibilities to join this lecture. And I will just jump right into the lecture since I want to leave adequate time for questions and discussion. What I want to do today is to give you a brief overview of kind of some of the major challenges that American society faces in terms of health, disparities in health. Now look at a broad range of disparities, and I want to show you some of the patterns. I have a lot of data and statistics because some of the things that I will show you are so stunning. If I told you and didn't show you the data, you wouldn't believe it. And then I want to end my talk by thinking about interventions. I devote a lot more of my time now to thinking about what we can do about the problems, both from a policy level as well as what can be done at the level of many institutions in American society. So I'm just going to jump right into the talk so we have some time. Okay, let's talk about some of the patterns of America's health, and let me put that into context. The United States spends more money in the world per person than any other country. In fact, according to the World Bank, half of the money spent in the world annually is spent in the United States. Spent on medical care, is spent in the United States. So we are, less than 6% of the world's population that consume the value of one-half of its medical resources. And if you look across certain procedures, half of the angioplasties done in the world are done in the US, half of the coronary bypass surgeries done in the world annually is done in the US. And in spite of our massive investment in medical care, we rank near the bottom of the industrialized world on health, and we are losing ground over time. So for example, in 1980, the US ranked 11th in the world on life expectancy. In 2006, we were 33rd in the world, tied with Slovenia. Countries like Cyprus, the United Arab Emirates, South Korea, Costa Rica, and Portugal all have better health than we do in the US. And I'll talk about disparities in health in a minute. The US profile does not just reflect the presence of minorities. If white America were a country in 2006, white Americans would rank 30th in the world in life expectancy. If black America were a country, it would rank 58th in the world. So we're showing that all Americans could be doing much better in health than they could be. All of us are far less healthy than we could or should be. And just to illustrate the point that all Americans could be doing better in terms of health. I'm showing you some data for this state of California from the Robert Wood Johnson Foundation's Commission to Build a Healthy America that I served as the staff director for. So it's the first national bipartisan effort to look at the challenges of America's health and make recommendations for the nation. What it's showing here is infant mortality by mother's education, and you can see the college educated in the state of California have the lowest rate of infant mortality. And here is infant mortality by race ethnicity in the state of California. You can see the excess risk for African Americans, dramatically higher rate for African Americans, with Hispanics and whites having very similar levels. What I want to emphasize though is a national benchmark. This is the national benchmark of 3.2. It reflects the current rate of infant mortality among college-educated women in the state where college-educated women are doing the best. There's no biological reason why the rest of Americans are not achieving that. That is what a real group of American women are experiencing today. And using this national benchmark, you can see that all groups in the state of California have worse health than they could. And it's not just the state of California. It's true, given the way we've defined it, of 49 other states, that even the best of, even the college-educated in 49 out of 50 states are not achieving a level of health that is possible. And I'm just showing you infant mortality in passing. The same is true for multiple indicators of adult health and child health. Okay, then in the United States, there are large geographic variations in health. Health varies from one zip code to another. A very widely used statement in public health these days is that your zip code is a better predictor of your health in the United States than your genetic code. And to a large degree, that is true. From one county to another, if you look at county variations in life expectancy in the United States, in some states there's much as a 14-year difference in life expectancy just based on which county you live in. And this is an example. This is the DC subway system, for those of you who don't know it. And if you board the subway station in downtown DC, the life expectancy is 77 years. At the end of the red line, it's 84 years. At the end of the orange line, it's 84 years. So just in a relatively small metropolitan area, you can find such large differences in how long people live. I mean, these differences of 7 years in life expectancy are huge. Life expectancy increases by 2/10 of a year from one year to the next in the United States. So a 7-year difference in life expectancy is about a 40-year difference in overall health in the US, given the rate at which life expectancy increases. And then there are large differences in health by socioeconomic status. I was trained as a sociologist, and I know that virtually everything in society varies by socioeconomic status. And just to give you an example, far removed from health, but as you will see at the end of the talk, maybe not as far removed from health as you might think of. This is data from ETS in Princeton, New Jersey on SAT scores by family income. And here you see ranges of family income. This is the whole SAT scores, but the point is still taken. And you can see at every higher level of family income, as family income increases, SAT scores increase. It raises intriguing issues of what we think SAT scores capture and what they measure, how should we use them. But what's true for SAT scores is also true for health. Life in America isn't just better at the top, it's healthier and longer at the top. Socioeconomic status, typically measured by income, education, occupational status, I may often abbreviate that in my talk by saying SES, socioeconomic status, is one of the most powerful predictors of variation in health in virtually every society where we have data. More powerful than genetics, carcinogens, and even smoking. Give you one example with US data. We seldom report data by socioeconomic status. This is data looking at the relative risk of premature mortality by family income, national data for the US. Premature mortality is defined here as death before the age of 65. So what I'm looking at is the probability of, by family income level, that someone will die before the age of 65. And you can see that low-income Americans are 3 times, relative risk, 3 times more likely to die before the age of 65 compared to high-income Americans. And you see the gradient effect. It's not a threshold effect. It's not that once you get above a certain level of income, it doesn't matter. With middle-income Americans still being twice as likely to die before the age of 65 than high-income Americans. Why is socioeconomic status matters so much for health? The WHO concludes that really the economic resources a household has shapes the opportunities to be healthy from the cradle to the grave. From the quality of childhood experiences, quality of employment in adulthood, even to the quality of life in retirement, everything is shaped by household economic resources, and thus it becomes a powerful predictor of health. Well, in the US, socioeconomic status is very strongly related to race. So when we see such large socioeconomic variations in health, we should expect to find racial differences in health. What most Americans don't realize, and I'll show you data in a minute on this, is that the gaps in health by income and education are larger than the gaps in health by race. I'll say that again, because most people don't realize that. We focus, when we state disparities, on racial, ethnic disparities in health. But the gaps in health between poor whites and middle-class whites is bigger than the black-white gap in health. And the gaps in health between poor African Americans and middle-class African Americans is bigger than the black-white gap in health. But this is an example of data from the Census 2010, using a measure of education, percent of Americans with a college degree or more by race, and you can see 31% of whites, markedly higher for Asian immigrants, Asian groups which are heavily made up of immigrants. 70% of the Asian population in the US are immigrants, much lower for African Americans, Latinos, Pacific Islanders, and American Indians. So you can see how race powerfully predicts variations in health. So not surprisingly, there are large racial ethnic differences in health in the United States. African Americans have higher death rates than whites, for 12 of the 15 leading causes of death. That's important, so it's not just one cause, it's not a single genetic factor. It cuts across a broad range of outcomes where the risk factors are very different. Blacks and American Indians have higher age-specific mortality rates than whites from birth to retirement years, so it's not either at one stage of the life course, it's across the entire life course. Latinos have higher death rates than whites for multiple outcomes like diabetes, hypertension, liver cirrhosis, and homicide. I don't have time to talk about this in length. We can get to it in the questions. But nationally reported mortality data is relatively accurate for African Americans and whites. It's not accurate for the other populations. It understates the death rates for Latinos. The nationally reported rates for Latinos, the actual rates are actually higher than the nationally reported rates. We can come back to that if we have time. Importantly, to understand what happens with Latinos and Asians, you have to look at groups that are heavily made up of immigrants. What we know in US data is that immigrants of all racial ethnic groups have better health than their native-born counterparts. White immigrants have better health, as measured by overall mortality or infant mortality, than whites born in the US. Black immigrants have better health than blacks born in the US. Latino immigrants do better than Latinos born here. Asian immigrants do better than Asians born here. Across the board, we have a healthy immigrant effect. The bad news is, the longer immigrants stay in the United States, the worse their health becomes. It's as if the data is screaming at us that there's something about the American way of life that is dangerous to your health. It's really true. So here is data. I'll show you two slides illustrating that. First one, this is national data for the United States of the prevalence of a DSM-4 defined psychiatric disorder. This is a person's in treatment and not in treatment. This does not reflect anything about seeking treatment. And I'm looking at 3 immigrant groups. This is Caribbean blacks. This is first generation. These are people who migrated to the US. Second generation, they were born in the US, their parents were immigrants. Third generation, they were born in the US, their parents were born in the US, but their grandparents were immigrants. Dramatic increase in the prevalence of psychiatric disorder. For Latinos, you see the same steep increase. For Asians, you see the big jump from the first to the second generation, not quite a steeper jump to the third. This is not something just about mental health status, so don't think of any theories about psychiatric illness that accounts for this. Here is another example. I'm going to show you data for allostatic load. I'm going to show you 2 slides of allostatic load so understand what allostatic load is. It's an attempt by researchers to get a summary measure of cumulative biological dysregulation across multiple systems. So these are the 10 markers used from the NHANES data: systolic blood pressure, diastolic pressure, BMI, glycated hemoglobin, albumin, creatinine, clearance, triglycerides, C-reactive protein, homocysteine, total cholesterol. So multiple indicators. All right. Let's look at what happens to Latinos in the US. So this is foreign born, and this is for persons 30 to 44 or 45 to 60. Let's just look at 45 to 60. And you can see that African Americans, these are US-born persons, have slightly higher levels. Whites are lower, and Latinos slightly lower. Mexican, born in the US, of Mexican descent. If we look at foreign-born Mexicans, 0 to 10 years in the US, they have a level of allostatic load similar to that of whites. By 21 years in the US, they have a level of allostatic load more similar to that of African Americans. So it illustrates the dramatic decline in health just within years in the United States. By generational stats, by the second generation, the patterns are even much more pronounced. One of the huge public health challenges that we face is what can we do about this? Are there interventions that we could implement that can reverse the downward trajectory of immigrants with lengths of stay in the United States? Let me talk quickly about some disturbing patterns in racial ethnic differences in health. One is called accelerated aging, that minorities are physiologically aging more rapidly. I'll show you examples of that. Another is, there's not just racial differences in the onset of disease, but racial differences in the severity and the progression of disease. So the course of disease is worse. There are more adverse effects of some risk factors. I'll give you one quick example. There's long-term negative health effects of exposure to early life adversity. So health is affected not only by your current circumstances, but to what you've been exposed from in utero and maybe even before that. There's some suggestion of intergenerational effects. The striking persistence of disparities is another pattern, and residual effect of race when is control, and documented adverse effects of psychosocial stress, including discrimination and institutional racism. So let me give you some quick examples of this. I'm not going to spend a lot of time. They're going to look at multiple body systems, but just illustrate some of these really striking, disturbing patterns. Breast cancer is one example of a disease that doesn't fit the pattern. White women actually have higher incidence rates of breast cancer in the US than African American women do. And it's consistent, middle-class women have higher incidence of breast cancer than poor women do in the US. But under age 40, the opposite is true. African American women have a higher incidence of breast cancer. So as a group, they have it less, but under age 40, which means African American much more likely to get it when young. Another example of the early onset of disease or accelerated aging. This is a study, New England Journal of Medicine, looked at the cardiac cohort. It's a large cohort, multi-site of cardiovascular disease, following persons from age 18 to 30. They've now been followed through age 25. This 20-year follow-up study found that incident heart failure under the age of 50, 20 times more common in African Americans than in whites. Here is a striking pattern. Arlene Geronimus documented this. Context. We think, socially, it's a good idea for women to delay childbearing from their teen years to later in life. We think it's not only good socially, but we think that biologically that might actually be a good thing, to let the woman be more mature when she has her first child. This is data for the United States, so it's not a sample. It's all births, all first births to women in an entire year. So this is all births, first births in the country. And Arlene Geronimus was the person who documented this and looked at the rate of neonatal mortality, death in the first month of life, a bad outcome. It's true for other birth outcomes, but I'm showing you one in the interest of time. And what she found, that what we expected to find, that if you delay birth from your teen years to your 20s, outcomes are better. That is in fact true in these data for white women. Here's the teen neonatal mortality rate for white women. Here is it in the 20s. And it's also true for Mexican American women. Here is the teen, here is the 20s. You see they go down. The opposite is true for African American women, where first birth in the 20s, the risk is higher than in the teens, and for Puerto Rican women, first birth in the teens is lower than first birth in the 20s. And remember, this is not a sample, this is all births in the US for a given year. How on earth do you make sense of this? Arlene Geronimus proposed what she calls the weathering hypothesis. And she argues that chronological age not only says how old you are, but if you're living in a bad environment, chronological age also says how long you have been exposed to bad environmental conditions and how physiologically compromised you are, how weathered you have been by your negative exposures. And she's done a lot of work documenting this pattern. Here is a more recent paper from Arlene Geronimus using national data for the United States. The same 10-item measure of allostatic load. I'm using the same measure of allostatic load. And what I want to show you here, that Arlene Geronimus was able to show, using this measure of allostatic load, think of it crudely as a measure of physiological aging. Let's look at the health, the average allostatic load score of whites at age 55 to 64. It's identical to that of African Americans 10 years earlier. So there's a 10-year gap in physiological aging across multiple physiological systems in the United States. This is national data for the US between blacks and whites. It's an example of what researchers are calling this premature aging. Gives you another example of the severity and course of disease, with outcomes being worse for minorities. This is a national data for the US, a study I did, published in Archives of General Psychiatry. African Americans have lower current and lifetime rates of major depression than whites. That's a surprise for many persons. But although blacks are less likely to get depressed, once they get depressed, they're more likely to be chronically or persistently depressed, more likely to have higher levels of impairment, so the levels of functioning is worse. They have more severe symptoms, and they're less likely to receive treatment. So although they're less likely to get the condition, once they get it, everything is worse. And that pattern exists for multiple other diseases, but we don't have 10 hours to go through this. Some risk factors have a more adverse impact on minorities compared to whites. Let me give you one example to illustrate that. It's true for both alcohol and tobacco. I'm going to illustrate it with data on alcohol. So alcohol-related mortality is twice as high for black males and females compared to whites. Black females use alcohol at markedly lower rates than whites do. Black males and among blacks and white, among males, the prevalence of use is very similar. So you wouldn't expect with lower rates for black women that they would still have alcohol-related mortality twice as high. Some more careful studies have documented that a given level of alcohol is associated with greater liver damage for African Americans compared to whites. National data for the United States, in national data, I gave a talk at Loma Linda once on alcohol. I'm not going to repeat that talk tonight, but today. But in national data, we often find a beneficial effect of moderate alcohol consumption on overall mortality. That does not exist for African Americans. In the ARIC study, that's a large cardiovascular disease cohort, a protective effect is found of moderate alcohol on incident cardiovascular disease and incident hypertension for whites. The opposite is true for blacks, so there's a dose-response relationship, any alcohol leading to worse outcomes. In the cardiac study, another large cardiovascular cohort funded by NHLBI, moderate alcohol consumption positively related to coronary artery calcification for black men. It wasn't, the cases weren't enough to look for women, and there wasn't that association among whites. So you see a consistent pattern. I'm showing you several different studies that all tell the same story, that any alcohol adversely affects African Americans more than it does whites. The same is true for tobacco. I'm not going to show you the tobacco data, but smoking one cigarette leads to higher cotinine levels for African Americans than whites. Just one cigarette. So the adverse effect is there. We don't really understand what these patterns reflect. It's an area of research that we really need to understand. My hypotheses are it could reflect interactions between these health behaviors and unmeasured social, physical, chemical exposures. It could reflect interactions of health behaviors with compromised biological systems due to other environmental exposures. And it could, in fact, reflect misunderstanding of the association between these health practices and health status, which is certainly the case in alcohol. I also talked about being able, trying to understand disparities, to understand life course. What has happened over the life course? Your health is affected not only by what you currently experience, but what you've experienced over the life course. So I'm showing you a paper by my research group, where we looked at the MIDAS national study, and we assessed the stressors that individuals face These are adults aged 35 to 90. We asked them about what stresses they experienced while they were growing up. So stressful events during childhood, relationships with parents, verbal, physical abuse. And what we found, looking at 5 markers of inflammation that we measured in these adults, we find among African Americans, early life adversity predicts, this is 30, 40, 50, 60 years later, the level of inflammation across multiple indicators of inflammation as adults. So again, what has happened in childhood has a long arm that reaches into shaping health currently. Another pattern I mentioned was the persistence of disparities. Here's life expectancy data for the US 1950 to 2006. You can see the gap in life expectancy in 1950. It's narrow in 2006, 5 years. But let's ask the question. This is the life expectancy of whites in 1950, 69.1 years. How long did it take for African Americans to catch up to where whites were in 1950? 1990, 40 years later. It's a 40-year gap in health between two groups living in the same society. In addition, I talked about the role of socioeconomic status, accounting for racial differences in health. The data is now very clear that in addition to socioeconomic status, there are other things about race that matter. So here is one example, national data for the United States, life expectancy at age 25. At age 25, the average white person in this country will live 53.4 more years, the average African American, 48.4 more years. There's a 5-year difference in life expectancy. Among whites, by education, the same is true for Income Australia education data in the interest of time, the difference in life expectancy between a white person who has not graduated from high school versus a college graduate is 6.4 years, bigger than the black-white gap. The difference among African Americans, again, is 5.3 years, again, bigger than the black-white gap. But look at the stunning pattern here. At every level of education, white high school dropouts still live 3.1 years longer than black high school dropouts. And the difference is even larger when we compare black and white college graduates. So what else is it about race that matters, even when we look at people of similar level of income and education? I just want to show you the pattern. This is not, that was national data for the United States, but I want to give you another quick example, just to show you this is not a fluke. It exists for multiple health outcomes. A cohort of all black physicians graduating from a Harvard Medical School about the same time of a cohort of all white physicians graduating from Johns Hopkins University. So they're all medical doctors practicing in the United States. You have explicitly control and social class. They all have the same job, same profession, trained about the same time. 23 to 25 years later, the black physicians have higher incidence of cardiovascular disease, earlier onset of disease, incidence rates of diabetes and hypertension twice as high, higher incidence of coronary artery disease, and if they got sick, much more likely to die. So virtually everything is worse, even though they are all physicians practicing in the United States. I had other examples of that, but in the interest of time, I'm going to move on. Why does race still matter so much? Research suggests there are 3 answers to the question. One is, we got to take the life course into account. Middle-class African Americans today are more likely to have been grown up poor, more likely to have been born low birth weight, more likely to experience adversities in early life. All indicators of socioeconomic status are not equivalent across race. $1 in the United States, on average, in the hands of a black or Latino person does not buy as much as $1 in the hands of a white person. You said, what are you talking about? Economists have actually studied this. Blacks and Latinos, on average, live in neighborhoods with poorer living conditions, but the cost of goods and services are higher in those poor neighborhoods. Life is not fair. They are living in worse conditions, but insurance costs are higher, gas costs are higher, groceries are higher. In fact, services are inferior in quality on average, but higher in price. Even the cost per square foot of rental housing is higher in poor black and Latino neighborhoods than in other neighborhoods. So that's when we say the non-equivalence. And then discrimination. Let me give you an example of the racial differences, the non-equivalence of economic status. So here is What I'm showing you here is national data for the United States from the US Census at levels of income, the levels of wealth. And to translate it for you, I am presenting in a way that I think you'll readily grasp. On average in the United States, for every dollar of wealth whites had, blacks had 9 cents and Latinos had 12 cents. This was from the 2003 Census report. I'll show you more recent data. If we look at the poorest quintile of income, so these are all Americans who fall into the same income level. For every dollar of wealth poor whites have, poor blacks have 3/10 of a penny, and poor Latinos have 2 pennies. If you look at the richest 20% of the US population, you can see how much income, wealth rich whites have. But for every dollar of wealth rich whites have, Latinos and African Americans who fall into the same income category, African Americans have 31 cents and Latinos have 35 cents. So at every level of income, there are large racial differences in wealth. And remember, wealth is captured. Income tells about the flow of resources into the household. Wealth is the economic reserves a household has. It's how much you have in the bank. It's the value of your home equity, the value of your second home, the value of your financial investments and instruments, and so forth. As bad as that was, it's worse. Because as a result of the housing crisis, the wealth of whites declined by 16%, but it declined by 53% for black households and 66% of Latino households. So today, the median wealth of whites is 20 times that of blacks and 18 times that of Latinos. This is the actual numbers if you wanted to see them. Let me talk about one more disturbing pattern, and then I want to talk about solutions. The added burden of racism. There's a lot of evidence now. You may be a much more sophisticated audience. I taught undergraduates for the last 25 years at Yale, Michigan, and now at Harvard. My undergraduate students were all born long after the 1960s. They tend to think that discrimination used to happen in the United States. Martin Luther King, Civil Rights Movement, discrimination doesn't happen anymore. That's where my students are. There's a lot of scientific evidence documenting the persistence of discrimination. Some of the best come from audit studies. Here's work done by Debra Pager, where she went to Milwaukee, Wisconsin, took 2 black males and 2 white males, judged them of equal attractiveness, dressed them similarly, sent them to apply for entry-level jobs. Had one of the blacks and one of the whites say he was out on probation, he had served an 18-month prison sentence for cocaine possession. Debra Pager found what you would expect to find. Whether you were black or white, if you had a criminal record, no criminal record, you were more likely to get a call back for a job. This is the difference. No criminal record among white, criminal record among white, less likely. But what she found was what we did not expect to find. It was easier for a white male with a criminal record to get a call back for a job than a black male whose record was clean. The resumes were otherwise identical. She repeated a study in New York City, found exactly the same thing, that the white felon gets a higher callback than a Latino with a clean record and an African American with a clean record. Evidence of discrimination persists in American society. There are multiple ways in which racism affects health. I'm not going to talk about them. I just want to give you one illustration, and that is the experiences of discrimination. Now, not all the discrimination someone encounters they're aware of. But what happens when you are aware of the fact that you were unfairly treated? I developed some 20 years ago a scale called the Everyday Discrimination Scale to capture one type of discrimination, not all of it, but it's the little day-to-day indignities and hassles. You're treated with less courtesy than others, you're treated with less respect than others. People act like you're not smart. You receive poorer service than others at restaurants and stores. And then if people report this, we ask them generically, and so we ask it in any society, with any racial group, and minorities are not the only persons who experience everyday discrimination. All groups do, but minorities experience much higher levels of everyday discrimination than whites do in the US, or I've done this in national data in South Africa as well. I want to show you the power of everyday discrimination, focusing on the research of just one researcher who's done work in the area. There are hundreds of studies, but Dr. Tene Lewis. She has documented that everyday discrimination, controlling for other factors, is linked to increased coronary artery calcification, is linked to higher levels of inflammation, is linked to higher levels of blood pressure, Among pregnant women who report every discrimination, they give birth to lower birth weight infants. It's linked to higher levels of cognitive impairment among the elderly. It's linked to poorer levels of sleep quality, both objectively assessed and with actigraphy and subjectively assessed. In a study of the elderly, it's increased to higher rates of mortality. And a most intriguing study, it's linked to high levels of visceral fat. So visceral fat is the bad type of fat that she was able, with using imaging data, to separate visceral fat from subcutaneous fat, unrelated to subcutaneous fat, but into visceral fat. So basically, we are documenting now that just this one dimension of discrimination is literally killing individuals across a broad range of systems. And I'm just showing you the research of one researcher using this measure. This is her data on visceral fat. Okay, I've talked a lot about the patterns and the problems. They're huge. What can we do about them? A lot we can do. The first challenge in terms of America's health and improving health is to provide high quality care to every client. Now, you'd say, why do you even say that? That goes without saying. Doesn't every healthcare provider do that? In reality, folks, this is exceedingly difficult to do. So, Kevin Schulman went to a medical convention and had 720 internists look at a videotape vignette of a patient. The patients were all actors, described identical symptoms with the same facial expression, claimed to have the same jobs, lived in the same place. Some were black, some were white, some were male, some were female. And Kevin Schulman found that the black patients were less likely to get the appropriate treatment, and women were less likely to get the appropriate treatment. It caused such a consternation, this was around 1999, that Congress in its wisdom voted to ask the Institute of Medicine to conduct a study to see if what happened at a medical convention with fake patients rarely happens when Americans go into healthcare context in the United States. The result was the Institute of Medicine report on equal treatment in 2003. I was on the panel. We basically found that across virtually every therapeutic intervention, blacks and other minorities receive poorer quality care than whites. I want to give you one example. Dr. Todd was an emergency room physician at UCLA Medical Center, and he asked a simple question. When a patient comes into the UCLA emergency room with a long bone fracture, broken bone in the arm or legs, does the ethnicity of the patient make a difference of whether the patient gets pain medication or not? So, you know, broken bone, in pain, does your race or ethnicity determine whether you get pain medication? Dr. Todd found that 55% of Hispanics received no pain medication compared to 26% of non-Hispanic whites. Dr. Todd was a good researcher, said confounded. Something else is driving it. So he statistically adjusted for whether they were male or female, whether they spoke English or not, whether they had insurance or not, whether they got injured on the job or not, what time they showed up at the ER, how long they spent in the ER, virtually everything you could think about. And the single biggest predictor of whether you got pain medication was that you were Latino. Dr. Todd conducted a second study. He said, could it be that Latinos have some distinctively cultural way of expressing pain that the providers are just not cluing in on? So he had physicians to rate the pain they thought the patient was in. He had patients to rate the pain they were in. And he found that the physicians could equally tell the severity of pain in Latino patients compared to white patients. But systematically, the Latino patients got less pain medication. Dr. Todd moved from UCLA to Emory University in Atlanta, repeated the same study at 3 large emergency rooms in Atlanta, looking at black and white patients, and found exactly the same thing. A black person shows up at the emergency room in Atlanta with a long bone fracture is less likely to get pain medication compared to a white patient. Remember, I've just talked about pain medication of Dr. Todd studies. This pattern is best documented in the area of cardiovascular disease, and it exists in every area of medicine, from the simplest procedures to the most complex ones. How on earth can we possibly make sense of these differences when we have the best trained medical workforce in the United States going to work every day to do their best? How is it possible for them to produce such a pattern of care? Today, I want you to think about a phenomenon that social psychologists have been studying for 40 years. It's called unconscious or unthinking discrimination based on negative stereotypes. And it's not about white people, and it's not about American society. It's about how all human beings process information. We process information, all of the complex cognitive data we have to deal with, by putting things into categories. If you're a normal human being, you do this. The question is, are there some categories that you have negative attributes to, that you have negative stereotypes, negative beliefs about, based on your socialization in your specific society? And what the research shows is that if you do, when you meet someone from a category and you have negative beliefs about the category, my next two words are important. It's automatic and it's unconscious. You will treat that person differently. In other words, you will discriminate against them. But you honestly will not know that you did it. There was absolutely no intent on your part. All that it takes to do it is what are the larger beliefs that you have, some of which could even be deep in your subconscious that you're not thinking about at the time. So I'm talking about race, but remember, if you have negative beliefs about fat people, about gay people, about old people, you will treat someone from that group differently when you encounter them. Conclusive evidence. This is done. This is how we all, I tell my students, I am a prejudiced person because I'm a normal human being. We all are capable of this. Where we differ is the society in which we were raised, what are the outgroups, what are the groups that we have negative stereotypes about. Many part of the processes results in this. I want to show you this recent study. These researchers have put together a database of more than 10 million words that reflects what the average American will read over their lifetime. Okay? So they've summarized what the average college-educated American will read in their lifetime. They've summarized American culture in a database. If you put American culture in the database, you can look at relationships among different variables. So in American culture, when the word black occurs, what most commonly co-occurs with black? Poor, violent, religious, lazy, cheerful, dangerous. So when an average American has stereotypes that blacks are poor, violent, lazy, and dangerous, they're not being a bad person. They're simply being a normal American. That's what American culture has fed you. White, what occurs with white? Wealthy, progressive, conventional, stubborn, successful, educated. For the fun of it, female, distant, warm, gentle, passive. Male, dominant, leader, logical, strong. The point is, these are stereotypes that we've all been fed. We don't have to think about it, this is what we've been fed. Okay, can we do anything about this? There's a wonderful paper by Diana Burgess and colleagues that summarizes everything we know from social psychology about the mechanisms and strategies that work to help us overcome these processes. The big one I would say is the difference between individuation and categorization. Categorization is normal, it happens without thinking. Individuation says, when I meet someone, I try to resist categorization, what gender, age, race you belong to, and focus on the unique qualities of this person. Look at them as an individual. There are other strategies that I don't have time to discuss. Implicit.harvard.edu is a website that helps you to identify what implicit biases you might have. But what else can you do in addition to providing care to everyone and overcoming these biases? We need to provide care that addresses the social context. What do I mean by that? If all we do at Loma Linda or anywhere else is to treat illness and send people back to live in the same conditions that made them sick in the first place, what have we accomplished? So the challenge is to not only treat the underlying presenting problem, but what can we do to improve their lives and the underlying social factors that drive their health? Let me give you an example. The Boston Medical Center, Dr. Zuckerman, is the head of pediatrics. He's been the head of pediatrics there for 30 years. When a primary care provider in the pediatrics unit of the Boston Medical Center sees a client, he or she can refer that client to a number of specialists. One of the specialists is an attorney, an on-site attorney paid for by the hospital. I spent a day at the Boston Medical Center Medical Legal Partnership, and the attorney directing the program told me, show me someone who is poor, I'll show you someone who has 3 or 4 legal problems, they just never define them as such. So for example, here is a mother with a child with asthma, but the asthma is driven by underlying poor housing conditions. There's vermin in the apartment and other deficiencies in the housing conditions. All the medications in the world is not going to solve that child's asthma problem if you don't get at the underlying problem. And when a mother has complained to the landlord that has never gotten any progress, when an attorney calls the landlord and explains that they're in violation of housing codes for the city of Boston, you get action. So it's using attorneys to help address some of the underlying social conditions that families face. It's one way of broadening the range of issues that is being addressed. The Medical Legal Partnership has a wonderful book out, Poverty, Health, and the Law, with readings and background readings of how you can do this. It's being done in some 80 cities in the United States. Different facilities are following that model. Another example, also born at the Boston Medical Center, Health Please, formerly called Project Health. What this does is even less high-tech. Instead of lawyers, there are undergraduate students who are trained to staff the help desk. And they interview each client coming in for if they have any needs in the area of food, housing, heating, or other social issues. And it's a job of that student, once they identify a need, to fill that prescription, to link that person to a resource that exists to help them address the problems they're facing. Again, it's taking a broader view of the individual. Here is another example, the Nurse Family Partnership model. It's a program that takes low-income, highly vulnerable teenage moms, has a nurse make a home visit to these moms before the birth of the baby, and continues those visits after the baby is born. And the nurse deals not only with the health issues that the mother faces, but deals with the broad range of issues: parenting, maternal employment, relationships with the child's father. And you would say it's really expensive to pay a nurse to make those home visits. Well, we found there's a $17,000 return to society for each family served, because it reduces other costs if you do this, and it leads to better outcomes for both the mother and the child. And we have 3 randomized controlled trials in upstate New York with white women, in Memphis, Tennessee with African American women, in Colorado with Latino women, showing this works. Why aren't we doing more of it? Another example would be a study done by Lynn Sine. Took 244 hypertensive patients, all low income, all have high blood pressure. One group got routine care, went to the doctor, got their medication, sent on their way. The second group got a trained health educator to have a class once a week for 12 weeks to tell them about their blood pressure, why their medication was open. And the third group was the intervention group. They used lay people from the community, trained them with the basics about blood pressure, but also trained them in all the resources that existed in the community to help people with the problems they might face. And these lay health workers made home visits, talked about blood pressure, but as they uncovered problems, referred people to the resources that existed. There was no revolution, they didn't change, they didn't provide new resources, just linked people to existing resources. What they found was 7 months later, the group that had received the lay health intervention knew twice as much about blood pressure. So their level of knowledge is high, one of the things you want. They were more likely to take their blood pressure medication, the group that had received the lay intervention. Compliance is a huge problem, so they're doing what their provider tells them to do. And 3, among good compliers, the medication was more effective in maintaining blood pressure control among the group that got the lay intervention. In other words, when the hypertension is understood and addressed within the context of people's lives, everything a healthcare provider wanted was improved. That the patients understood what they were supposed to do, they did what you asked them to do, and what they did worked. It's taken the context of the patient and addressing their problems within the context of their lives. What else do we need to do to improve America's health? We need healthier lifestyles. We need to reduce smoking, improve nutrition, reduce obesity, increase exercise. We need to do all of these health behavioral factors. We are doing poorly. Here is data from CDC. The The percent of Americans eating 2 or more servings of fruit per day, this is 35%. By race, by education, nobody is above 35% virtually. Eating 3 or more servings of fruit per day, here's 35% again. So Americans of all racial, ethnic groups, of all educational categories, are not even coming close to the level of 5 servings of fruits and vegetables a day. And CDC and National Cancer Institute says 5 servings of fruits and vegetables a day is not enough. You need 9 if you're going to reduce your risk of cancer. 9 servings of fruits and vegetables a day. So I'm saying there's enormous opportunity for us to improve our health. The China study highlights the centrality of nutrition. Dr. Eslin's work highlights the importance of diet and nutrition in improving heart disease. Neil Barnard's work and that of many others illustrates the power of nutrition to help manage and control diabetes. There's a lot we can do. We need to change health behaviors. But folks, a Just Say No campaign is not enough. People need to take individual responsibility, but there's also a social responsibility to create the opportunity. Some Americans live in places where the healthy choice is not even available, where it's not safe to go outside and exercise, where there isn't a place selling fresh fruits and vegetables in their neighborhood. So we need to think of a comprehensive approach, and smoking provides us an example. We've been somewhat successful in reducing smoking, but it has taken many organizations with multiple intervention channels, with economic inducement, with laws and regulations, all working together to get us to what we need to do. What I'm saying is we need to move upstream. What do I mean by moving upstream? We need to change the social, physical, and economic environment that determine health and health risks. This is complementary to an individual approach, and it means that we change the culture around the individual where the healthy choice becomes the easy choice. We've done this before. This is not a new idea. If you look at seat belts in automobiles, laws regarding road safety, elimination of lead paint and gasoline, we didn't leave it up to individuals. We changed the culture. We made it easy to do the healthy thing. There are a lot of ways in which we can think of addressing interventions to improve physical activity, and I'm just illustrating some here with different kinds of policies or laws that we can do things that will make people healthier. We can think also about nutrition interventions. There are multiple things that we can do through laws, through institutional policies, through taxes, to get Americans to eat healthier. Basically, I'm saying we can improve America's health. We need to invest in schools, sidewalks, produce markets, preschool programs, parks, jobs, housing, transportation. We don't think of these as health policy, but all of these are fundamental health policies because where we live, learn, work, and play, and the opportunities to be healthy in the places where we spend most of our time drive our health behaviors, and we can make changes in those areas and improve health behaviors. And somebody says, do we have a shred of evidence that if we did this, it would make a difference? If we change the neighborhoods from people living in an unhealthy community to a healthy one, and you can think of multiple dimensions in which we do this, will it improve health in any way? I want to talk about the Moving to Opportunity study. It's just one study. It's gotten a lot of attention because it was an experimental study. You took poor people living in low-income housing projects, and you randomized them to receive a voucher to move to a less poor neighborhood. No health intervention, all you did was change the neighborhood environment. Immediately, 3 years later, improvements in mental health of parents and sons. 10 to 15 years later, the paper published in the New England Journal of Medicine in 2011, lower levels of obesity, lower levels of severe obesity, lower levels of diabetes risk. No health intervention, no education classes, all you did was change the neighborhood. Just simply changing the neighborhood led to improvements in health. I'll give you another striking example, the Perry Preschool Project. Low-income children living in a housing project provided random assignment, early childhood intervention program. The kids have now been followed 40 years later. At age 40 or 40, so 30-something years later, at age 40, those who received the program, higher levels of education, higher levels of income, higher levels of savings, higher levels of home ownership, less involvement with the social service system, less involvement with the criminal justice system, and for every $1 invested in an early childhood program, there's a $17 return to society. If you know where I can invest $1 and get a 17-color return. Please tell me before I leave. It's an enormous, so what I'm saying is we have high-quality scientific evidence pointing us in the direction. Why? Because the strong link between education and health. One's biggest health strategy for the next generation is improve education, which leads to better health. Let me conclude with two other, quickly, and I want to look at the time. I want to give you two more interventions. And what's striking about these is how simple they are. The results are mind-boggling because they're so powerful. They address a problem in education for minority students, and it's a problem called stereotype threat. Claude Steele, faculty member at the University of Michigan, then Stanford, then Columbia, back at Stanford, has studied this. He took undergraduate students at Stanford. These are students good enough to get into Stanford. Black students, randomly divided them into two groups by the flip of a coin. Half of them are told, take the test. The other half are told, take the test, and blacks do more poorly in the test than whites. The group told that blacks do more poorly, did more poorly than the other group. He can produce the effect simply by telling some of the black students, write your race on the top of the paper before you begin the test. Simply having them write their race leads to poor performance. It's not about blacks. He can produce it among white women. If he brings two groups of white women, one group told, take the test, the other group told, take the test, and women do more poorly in the test than men. The group told that women do more poorly, does more poorly. He's produced it among white males. Brought white males in, divided them into two groups. One group told take the test, the other group told take the test, and whites do more poorly than Asians on the test. The group told whites do more poorly than Asians does more poorly. It only works in an area where a group is stereotype vulnerable. So among women, it only works on tests of quantitative ability. It does not work on tests of verbal ability, because the stereotype is women outperform men verbally, but that women are not as good as numbers with men. In one variation of the test, one of his colleagues did it with Asian American women. If you made the stereotype of gender salient, that they were women, the women did more poorly, the Asian women did more poorly. If you made the fact that they were Asian salient, it enhanced their performance, it did better, because the stereotype is that Asians do better. So it plays to the stereotype. He brought a group of, they did a group study with black Caribbean immigrants. Told a group of black Caribbean immigrants, blacks do more poorly, they did better. Told the children of black Caribbean immigrants that blacks do more poorly, they did more poorly. Because you see, it has to do with where you were socialized and what other beliefs you were taught. It has to be in an area of stereotype vulnerability. What can be done about that? Let me tell you about two powerful interventions, and then I'm going to close. They took these are two randomized double-blind experiments with black and white 7th graders. The intervention is simple. You bring 7th graders in one class, takes less than 45 minutes, and you tell them, I want you to think about what value is most important to you. Are you a caring person? Do you love your family? Is it honesty? Whatever value is most important to you, and write a paragraph on why that value is important to you. The goal of it is to enhance self-adequacy and self-worth. What they found, that the students who got the self-affirmation condition, they earned higher grades in that course and in every other course. The improved grades was evident for 70% of the blacks. It didn't matter whether they did it once or twice, just once works. And this one intervention reduced the racial achievement gap by 40% in those 7th graders. No effect of the intervention among whites. A 2-year follow-up study found the positive effect was evident 2 years later. It wasn't just for that academic year. 2 years later, the students who got the intervention are still doing better. Lower achieving black students showed the greatest benefit. The intervention also affected their perception of their ability to succeed in school. It reduced the racial achievement gap and reduced the number of black students placed in remedial programs. They've also done a similar self-affirmation intervention among women and found that it reduced the black male-female gap in grades in the STEM sciences. So dramatic effects just affirming the value of an individual, enormous impact on health, on educational performance, which will have an indirect effect on health. Last study, social belonging intervention. They've done studies of many minority students, especially in persons who are first generation in college. When they begin to encounter difficulties in college, it reinforces for them that they don't belong. That this is not made for them, they're not cut out for this. And so the design of this intervention was say, let's do two things. Help them to understand that everybody does poorly initially. It's normal to have challenges, and that it will get better over time. And what they found, they did this with Stanford undergraduates in their freshman year to help the students internalize the message. They told the students, we want to tape you sharing the message because we want to share this new scientific research with incoming freshman students in the future. So you have to learn the information and we'll tape you saying it. And that was the research strategy of helping them internalize it. What they found, one intervention in their freshman year, they tested them as seniors. The students who got it increased academic performance. It reduced the black-white achievement gap in Stanford students by 1/2. It reduced doctor visits over their 4 years in college, and it improved their self-reported health over their years in college. Dramatic effect of a simple social belonging intervention having powerful effects. Let me conclude just by saying it's about all of us. The health of America depends on the health of all Americans. Too many Americans are sicker and dying younger than they should. Millions of Americans are suffering from diseases that could be avoided. America's health problems hurt our productivity. When people are sick, they don't do as well at school, at home, at work. Improving America's health will not only improve the economy, but it will improve the quality of life for millions of Americans. And let me conclude by pointing you to some resources for additional help. The Robert Wood Johnson Foundation has a website that has wonderful resources. CountyHealthRankings.org. Anyone interested in health should be familiar with that website, CountyHealthRankings.org. It's a website that ranks the health of every county in every state. It's state-specific ranking, and it ranks not only the health, but the determinants of health, health behaviors, clinical care, social and economic factors, physical, environment, and the website not only tells you what the problem is, there are resources on the website that summarizes all of the interventions that can help you to change all of the factors that drive health. It's an absolutely wonderful resource. County Health Rankings.org on natural causes is a tool that raises awareness levels. The Biology of Disadvantage is a publication in the New York Academy of Sciences that has wonderful resource for those who are interested in all the science behind this. I'm a co-author of one of the papers in this, but it's a wonderful resource on the topic. Okay, conclusions. The healthcare system reform is critical but insufficient to improve America's health. Social factors like education, housing, transportation, the environment can have decisive impacts. There are promising approaches from around the country that are making a difference now, and there are many more other interventions along the lines I spoke about. Health professionals need to work with other sectors to bring resources together in a concerted focus to modify where and how we live, learn, work, and play. What I'm saying is health, medicine, and public health alone can't solve the problem. We need to work with all sectors of society, and we need to attend to those furthest behind. Margaret Mead said, never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. I believe you are thoughtful, committed group of citizens. We can change the world. We can make America a healthier place. Thank you.
More than one language. One. Another thing is that cultural connection. I speak English. I am a Latin, so it's that connection. It seems that that's missing in the healthcare system. Language and cultural connections.
Okay, so we've got 2 points. I don't think it's really a question as much as as the need to ensure that the effective delivery of care requires effective communication. And can I broaden your point? So I completely agree with you. We need people who speak a language. But there's also a lot of evidence that indicates that the average healthcare provider in the United States uses medical terms that they assume their patients understand. So don't believe that because they both speak in English that communication is taking place. So that really using simple language to patients to understand. Patients do not interrupt the doctor and say, no, I didn't understand that term. Just even simple as terms as glucose are terms that many patients don't understand that the healthcare providers use. So the need for that is important. But I can tell you what the problem is. I had a professor, and this is not an original joke. It came from one of my professors at Andrews. He said that there was a widely held belief in parts of Europe that the language of heaven would be German. But he said they had changed their mind because God had reconsidered things. And God has now made the language of heaven English. The reason? Americans are too lazy to learn anything else. Okay.
I want Florence from Harvard to help.
Harvard is looking for friends. No, but your point is very well taken. I am painfully aware of all the challenges that San Bernardino and many other cities in similar situations face. To be honest with you, I sit on the board of Loma Linda, and one of the reasons I sit on the board of Loma, I accepted the invitation, is Dr. Hart. He has a vision and a burden for San Bernardino and for things that can be done, and I love to support people who really have a vision. I'm not saying that we're doing everything perfect, but I think the leadership of this institution has a vision and has ideas that we are discussing on the board of trying to address some of the issues. But I do think that, can I go into a theological moment here for a minute? I do think that it's not by chance that San Bernardino sits next to Loma Linda. Jesus lives in San Bernardino because he said, inasmuch as he did it unto the least of these, he did it unto me. And when he told this wonderful parable of the rich man and Lazarus, the rich man who ended up in hell did nothing to Lazarus when he was alive. In fact, he even allowed him to sit in front of his gate, and a poor beggar in front of his gate is bad for the property values. But he allowed him to sit there. But he neglected him. He lived his life as if that poor man did not exist. And we in Loma Linda cannot live our lives as if San Bernardino does not exist. Enough said. Yes?
Dr. Williams, you talked about the need for us to take a broader approach to reducing health disparities. You talked about going into the neighborhood, the community, doing various interventions and so on. What if we were to do something like that and we were actually able to see better health outcomes for various groups of people? Do you think that there is a fear in America that people will actually become healthy if we do these things, and what it will mean for our money, our bottom line? Do you think that we are addicted to the type of money that we bring in, the various hospitals, the healthcare providers, everybody? Do you think we're addicted to a big, heavy pocket? Do you think that we're somehow okay with these things because it brings in money? Are we ready for people to actually get healthy? I just want to know your opinion.
You've asked a good question. I do not believe that there's some terrible conspiracy where people are saying, no, we don't want the health to improve in order that the system, that we could make more money. Two economists who both served on the President's Council of Economic Advisors did a calculation, it's a published paper, of what it costs the US economy that we are so unhealthy as a nation. And they calculated that if all Americans had the health of the college educated, the US economy would save $1 trillion a year. So the poor health and the related lost productivity and the earlier death rates of people in their prime years of life is costing the US economy $1 trillion annually. Having said that, I do agree with you that we have a system. The healthcare industry is the largest industry in the United States. And our system functions with a certain set of incentives. And all the debate, most of the debate over Obamacare was really about money. It's about who wins and who loses and whose revenue streams might be affected. So I do think that there is, and I would also go a step further to say, and let me quote the CDC so it sounds not like a political speech. The Centers for Disease Control has estimated in the last 40 years, if you look at annually how much we spend on medical care of our health dollar that goes towards prevention, it's never been more than 2 cents or 3 cents on the dollar of our medical expenditures that go on prevention. So we are not preventively oriented. There are no incentives to do that. If someone wants to read, there's a wonderful commentary by Dr. Caldwell Esselin in the American Journal of Cardiology, showing how all of cardiac procedure, the whole system of cardiology, and he was a cardiac surgeon at the Cleveland Clinic, is heavily focused towards treating the symptoms and not getting at the underlying problems. And he has shown that with nutrition interventions, he's literally able to reverse heart disease just by changing the diet of patients. So I think there's a system set up with incentives, but I don't think it's a conspiracy to keep people from being healthy per se. But I do think there are certain incentives that keep the system functioning the way it is. Yes. I see you in your hand next. Yes.
Here, normally in the School of Medicine, there are a lot of basic scientists that are beginning to explore biological determinants of health disparities. And this is a growing field, but it's still limited. Could you talk a little bit about what's the role that a basic scientist plays in reducing health disparities?
Absolutely, that's a great question. So one of the, and I didn't get into this at all, I talk sometimes about the role of neighborhood and place, and the role that segregation and how it has created distinctive environments. I hinted at it when I talked about Arlene Geronimus's work, but I didn't elaborate on it. If we are saying that African Americans and Latinos and Native Americans live in distinctively bad environments, their neighborhood conditions, their housing conditions are worse, there's an important scientific question that the research community hasn't grappled with. Biology is not static. Biology is adaptive to environmental conditions. So if you look at some population groups in your society that are living under different conditions, you need to begin to ask the question, is how does these adverse living conditions leads to different biological profiles and different patterns of biological dysregulation, because the environment ultimately affects health through fundamental biological processes. So I think the research of basic scientists is critical to helping us identify, it is a catchword being used by researchers today, of how does the environment get under the skin, but helping us to see what are the pathways by which the environment adversely affects health. I mean, it might help us as well in targeting interventions at some of the intermediate pathways, although my ultimate goal for interventions would be to move as far upstream as possible so that we can stop the processes from occurring in the first place. On the other hand, that prevents those people who haven't been affected yet, but for people who are being affected now, whatever we can do to intervene on intermediate biological pathways, would be potentially very helpful. So, important. Question at the back, and then I'm going to come to this question here, and be probably almost out of time. So, there's a lot that needs to be done within the education system. The Education Trust is one of the top education advocacy organizations in the U.S. It's based in Washington, D.C. There is a book on the Education Trust website, a report entitled, what was Obama's slogan again? When he first ran. I'm blocking on it. No, not President James. Yes, we can. Actually, and it was before Obama. It's entitled, Yes, We Can. Thank you. Yes, we can. If you Google Yes, We Can Education Trust, it will take you to a summary of the scientific evidence of what can be done to improve education. The problem is I spoke to the head of the Education Trust. She was a commissioner on the RWJ commission that I mentioned earlier. And I talked to her that the barriers to doing it are non-trivial. So for example, we know in the United States, the single biggest predictor of student performance is teacher quality. The single biggest predictor of student performance is teacher quality. And what we have in the United States is the best teachers are teaching the students who need their help the least. And in the most disadvantaged neighborhoods, you have, on average, the worst teachers. And you also have, in the public school system I'm talking about, you also have a system where public school teachers get tenure, and typically after 1 year or 2 years of service, where it is no longer possible to replace them. So we have an entrenched system that has incentives built into it that is not delivering the highest quality of education to our kids. And there are all kinds of political ramifications for trying to address that. But I would point you to Yes We Can as one thing that can be done. I think there's a lot can be done at the local level, and there are multiple schools. In fact, even in that report, it shows you of schools in poor Latino neighborhoods, and poor African American neighborhoods, and poor Native neighborhoods that are doing a wonderful job. We have time for one last question. His hand was up, so let me take him, and then last question. I'll be here for a few more minutes before I have to go back to the board meeting. Yes.
This has already been alluded to and mentioned elsewhere. The government is generally very good at collecting taxes, and in spite of various problems and inequities in that respect, but relatively very bad at allocating resources, which is perhaps one of the reasons why we have some of the problems that we have. Usually whenever there is an allocation of resources discussion, there is immediately confounding politics that comes in and all kinds of territorial and whatnot. And the question that bothers me, and that I think probably you have pondered on, and I would like to very much see your point of view. What conceptual infrastructure is necessary for us to better allocate resources which we already have, so that an improvement can be had?
I agree with you that in the United States, and I'm qualifying what you said, so I'm not saying government in general, but in the United States, government could do more to allocate resources, because I can look at societies where it's different. So let's give you two quick examples as I close today. In the United States, one of the strongest predictors of a child growing up in poverty, and by the way, we have the highest child poverty rate of any industrialized country, and one of the strongest predictors of a child growing up in poverty in the US is a child being raised by a single parent. That is not inevitable. If you look at data from UNICEF, the percentage of children being raised by single parents is higher in Sweden than in the US. That's correct, I'm using UNICEF data. Also, if you look at the rate of poverty among children in Sweden and the US, before taxes and transfers, the rates are similar. The US is slightly higher than Sweden by like 2 percentage points, like 26% versus 24%. But after taxes and transfers, which reflect policy choices, Sweden reduces its child poverty rate from 24% to like 2%. After taxes and transfers, the US reduces its child poverty rate from like 26% to 24%. So all I'm saying, it's not inevitable, it reflects the choices we make as a society. Let me give you another example. Which country in the world has the highest life expectancy? Japan. In 1960, Japan had much lower life expectancy than most industrialized countries. In fact, the US had higher life expectancy at birth in 1960 than Japan. What happened to Japan since 1960? They did the things that America made them do after World War II, which America made Japan become a more egalitarian society, made Japan invest in a public health system, and changed Japanese society. And you can see, I have a chart, I didn't bring it, that shows the striking increase in life expectancy in Japan as a result of policy choices that were made. The point I am making is, the problems we are talking about are not inevitable. They reflect policy choices you make. And I'm going to leave you on a very provocative note that I want you to think about, because I went back recently and read the 1899 book of W.E.B. Du Bois, an influential early social scientist in the United States. And he wrote, the 1899 book was entitled The Philadelphia Negro, and he has a chapter on Negro health in Philadelphia. And everything that I said with all data is in his chapter. But he said this in his book: the most difficult social problem in the matter of Negro health is the peculiar attitude of the nation towards the well-being of the race. And Du Bois continued, there have been few other cases in the history of civilized peoples where human suffering has been viewed with such peculiar indifference. And the single biggest political challenge we face in the United States is that the American electorate does not care about the poor. They believe that people who are poor, it's your own fault. That there is opportunity here, and if you still thought it's your fault. That's number one. I'm generalizing, but there is scientific data behind what I'm saying. And then there is less concern about racial ethnic minorities and about the poor in general. And researchers talk about this, they call it the empathy gap. There's an empathy gap in this country when it looks at issues that affect African Americans, Latinos, Native Americans. And one of the big, there is the government, but who puts the government in power? We do. So we can change the government if we are mobilized to do it. And one of our biggest challenges, I think, for this whole area of work is what we can do to tell the story of the plight of poor, disadvantaged groups in our society in a way that resonates and connects with the American electorate, that we will feel, because we don't act based on facts, we act based on our emotions, we act based on our affect. So how can we tell the story in a way that connects with the American public, that they feel this is unacceptable and we will do something about it? America is a very generous society. There's an earthquake in Haiti, and people are generously providing resources to help. One of the challenges is how can we build and close that empathy gap that researchers have identified and really get people mobilized to try to do what can be had, to take the actions, because we know what needs to be done to improve the health of all. Thank you so very much for your time in this session.